who has rightly said that hystroscope should be considered the stethoscope for the uterus. Today, why are we talking more about hystroscopy and why this topic of hystroscopy and making it so safe has been addressed by Ferty9? We are all humans, and for humans, uterus is their first home. So this topic is definitely validated in this Fertygnan CME. The flow of the talk today shall be on the basic instrumentation and the room setup needed, the basic principles of hysteroscopy, the distinction media, the safe hysteroscopy, role in infertility, the trials, Cochrane review, and a take-home message. Hysteroscopy had to wait for technical innovations in endoscopic fields. Difficulty in distincting the uterine cavity, the friable nature of the uterine mucosa, and the deadly bleeding that can happen, and the need for anesthesia and cervical dilatation were its hindrances in initial days. It has soon surpassed the dilatation and curettage for gynecological indications and also decreased the need for laparotomy for treating septate uterus and different uterine anomalies. And now it has set itself as a gold standard for endoscopic surgeries. Before doing a hysteroscopy for any patients, first, suppose you have posted a case, you have to be very sure and know which type of hysteroscopy are you planning in your theatre today. Is it a level 1, level 2 or level 3 hysteroscopy? Level 1 will be a just diagnostic hysteroscopy and a target biopsy with the removal of a simple polyp. Level 2 will be a proximal fallopian tube cannulation and removal of a pedunculated fibroid, and level 3 goes to the resection of the uterine septums, endometrial ablations and resections of submucous fibroids. This is the basic instrumentation which is to be there on your trolley. This is the uterine sounds, speculums, the sponge holders, the basic hysteroscope with its outer sheet, and this is the resectoscope, and when you are using a resectoscope you should have a TURP set available with you. These are the different diagnostic hysteroscopies which have been shown. A flexible fiber optic hysteroscopy, a miniature hysteroscopy has come up with a diameter of 2 mm which can be used in your daily office procedures. And these are the different instruments inserted through the office hysteroscope, the forceps, scissors, unipolar and bipolar electrodes. And this is the telescope. Remember that to see the uterine cavity, the basic wattage should be around 150 watts when you are buying a light source. For the fiber optic smallest of the hysteroscope, you need as high as 300 wattage. And the video cameras have gone from a single chip to 3 chip and now has come the HDs. Lithotomy position is the ideal position to do your hysteroscopy. This is an endoscopic trolley which has to be there in your theatre. And what are all the systems to control the pressure and flow? Now that you have started your hysteroscopy, what do I use? I have a basic setup. Is gravity fall system okay, or should I use a power cuff, pressure cuff, or all of us should have a Histromat? The basic Histromat is as costly as 4.5 lakhs. Should all of us have this? No, definitely. For a level 1 and most of the level 2 surgeries also, you can do your hysteroscopies with a gravity fall system. The Histromat has a suction irrigation system, and it is important to maintain this suction irrigation continuously to have a clear flow. And it has a preset flow rate, suction and irrigation pressure which automatically adjusts the inflow and outflow of the fluid. A point to mention here is inflow accounts for how many fluids you have been using and also whatever your anesthetist has been using. Suppose you have used just 3 to 4 or around 3 to 4 bottles of normal saline which were around 500 ml, it amounts to 2 liters, and your anesthetist has pushed out another 3 liters. It becomes 5 liters and your output is not as much as it. Definitely the patient will go into hyperdynamic circulation. So you have to watch what anesthetist is pumping in apart from what fluids you are using also, and the ideal flow rate is around 200 millimeters of Hg and the ideal outflow pressure is around 75 millimeters of Hg. This is a resectoscope which has been assembled to do the procedure. We can see here that it has an inflow tract, outflow tract and an outer sheath and a cable connected for the cautery to work. And this is a ideal operating room setup. We should have you operating from the foot end of the patient, the anesthesia monitor, the anesthesiologist at the head end of the patient, and electrosurgical unit on the right side of the patient's leg, and a monitor near the almost at the thigh level of the patient, and your table on the right side. So we are all set with all the available instruments, be it a high level or a lowest setup, whatever we have. We are starting to do a level 1 or a level 2 or level 3 hysteroscopy. The most important thing which we have to learn, the basic principles are, what is this viscosity of the media? What is high and low? High means it has more number of particles, low means it has low number of particles. It's a simple way to tell. That's what we have learned in our physiology. And does it have an electrolyte content or not? This is most important, because when you're using a unipolar system and doing a septal resection, which is most commonly done with glycine, which is a hypoosmolar media, you should be very careful. You should never use a normal saline with a unipolar system, because electrons flow from the generator to the loop, to the tissue, then to the neutral electrode, and there should definitely be a non-conductive media for this. If you use a normal saline when you are using a unipolar system, what happens is these electrons get dissipated and the tissue doesn't get any reaction. So the whatever surgery you are doing, it doesn't happen, and it's very minimal tissue which will be cut. When using an isotonic saline, the path traveled by the electrons is unknown. That's the reason why you should not use saline while doing a unipolar current cutting. And thanks to the technology, the new generators have a cutting power adjusted to the tissue resistance. This is a very good article which I have seen on the net while preparing for this CME. This is an AAGL practice report guideline for the management of hysteroscopic distending media, which every one of us have to read before embarking onto a hysteroscopic surgery. This shows the different distension media which are available. Normal saline, which can be used for a diagnostic and operative hysteroscopy, which is isoosmolar and electrolyte free, and it can be used for mechanical cutting with scissors, a bipolar or a razor. And of course it is not recommended with monopolar energy, as it disperses the electric current without having any surgical effect on the tissue, as I have told. Ringer's lactate can be used in both the situations. Glycine can be used in operative hysteroscopy. It is hypoosmolar and it has to be used with monopolar current. In the same way, dextrose and sorbitol. The incidence of fluid overload will vary according to the case mix and type of hysteroscopic surgery. In general, when using large diameter resectoscopes, the incidence of fluid overload should be less than 5%. So don't be afraid of fluid overload before starting to learn hysteroscopy or doing a level 1 surgery, because it's not very common. The clinical course and outcome of all women with fluid overload should be audited, of course. This should include the unrecognized fluid overload which your anesthetist has been pumping. The important point all of us should know about this fluid dynamics is, what is fluid deficit? It is a difference between the input and the output. Input means what you are using and what the anesthetist is using. A fluid deficit, what is an ideal fluid deficit? A fluid deficit of more than 1000 ml should be used as threshold to define fluid overload when using hypotonic salines in a healthy woman of reproductive age. Healthy woman has been mentioned means she is fit and healthy. Suppose she is having any underlying decompensated disease like a minor cardiac issue, then it has to be restricted to around 750 ml. A fluid deficit of 2500 ml should be treated as threshold to define fluid overload when using isotonic salines. So this can go up to around 3500 ml also sometimes, and it has to be restricted to around 1500 ml in an decompensated patient. So as beginners, it is always better to go with an isotonic normal saline and use a unipolar current. This is a very good pictorial representation of how to go about and how does the damage occur in a case of resection of submucosal fibroid. As we can see here, the overlying endometrium on the submucosal fibroid, once you start resecting, you will be resecting the endometrium, then the submucosal fibroid per se, and almost when it is invading the myometrium to less than 50% is the stage when you can do a submucosal resection of the fibroid. Beyond that, you should not do it hysteroscopically. Surgeon should understand the factors that can lead to a systemic fluid absorption. Means this case selection is most important in such cases. High uterine distension pressure, low mean arterial pressure, means the patient is already in hypotension then definitely you're going to fluid overload the patient. And when you're invading the myometrium very deeply and you're going ahead with a very prolonged surgery and you're going ahead with a very large uterine cavity, these all increase the likelihood of systemic fluid absorption. And how about the myometrial vessels section? It has been documented that when the myometrial vessels are around 400 to 500 microns, per minute of invasion, 9 ml of your fluid is going to go into the plasma. And if it is greater than 1 millimeter vessel section, around 400 ml per minute with gravity system infusion and 250 ml per minute for Histromat. And never exceed your operating time maximum of 30 minutes. Suppose you're a beginner and you're unable to do your surgery, suppose a septal resection or a submucosal fibroid resection, always it's better to counsel our patients that is, this surgery might be done on a second look also. In that way, we'll be very safe and we can restrict to this time limit so that we will not have this fluid overload. So, here are the small tips and tricks to how to go about hysteroscopy. Always allow free flow of distending medium through the system, which will eliminate the air embolism. You started your hysteroscopy. I'm doing a hysteroscopy with normal saline. Always see to that in the IV set or the TURP set which you are using, already it is full. The tube is already full, so that air embolism doesn't occur. This is a very important trick the beginner should know. And remember to do the hysteroscopy in the proliferative phase, because always remember that the isthmus doesn't give way when you do it in the secretory phase. And the mucosa is better to see in a proliferative phase. The morphological changes are very minimal in the proliferative phase. And suppose you're not able to pass the sound only, what do? Shall I abandon the procedure? No. The 2.9 mm hysteroscope or a 4 mm hysteroscope also, you can take out the outer sheet and you can go how the axis is going. Means see and do the surgery. That is what every one of us has to remember. And you have to adjust the right source, sometimes right side, left side, posteriorly or anteriorly, depending upon whether the uterus is acutely anteverted or retroverted. This is a very important tip the beginners have to know. And suppose you find that everything is so hazy, just open up the outflow tract. Let some of the fluid go. Then the cavity will be visualized. And sometimes you might have to touch the mucosa so that the camera is visualized properly. In a nutshell, the movement of hysteroscope should follow the uterine anatomy. What are the contraindications? A pelvic inflammatory disease, acute cervicovaginitis, intense metrorrhagia, and a pregnancy. And here comes to the complications. Overall incidence of hysteroscopy complications are just 0.95%. So definitely we all can start doing level 1 hysteroscopies with the minimum setup we have. And the most frequent of them are a hemorrhage, which accounts to 2.4%, uterine perforation, which accounts to 1.5%, a cervical laceration around 1 to 11%. Intra or immediate postoperative complications, you have to involve an anesthetist also in their management. These usually mainly occur due to cervical dilatation, the distension media, and the technique what you are using. And here goes the intraoperative complications, which can be arrhythmias, a uterine perforation, distension media related, a gas embolism, a hemorrhage due to cervical laceration, and of course the electrosurgical burns. The light complications include PID, intrauterine adhesions, hematometra, and post-ablation sterilization syndrome, which so happens in endometrial ablation, which is over-resected. Perforation, this is of course the most commonest complication. This can happen during cervical dilatation or insertion of a scope. How do you recognize it? You have happily gone inside the uterine cavity. Suddenly you feel that your instrument is going beyond the fundus. It means your procedure, you can feel that something is given way. Then you have to definitely suspect that there might be a perforation, and suddenly you lose the visualization and you can see the momentum popping up from the fundus. And sometimes, if you are very unlucky, you can see the bowel also at the level of the fundus. And sudden bleeding, your visualization was very clear, but suddenly you will find there is more amount of bleeding. Suddenly you will feel that find that the fluid deficit has increased, because whatever fluid you are pumping is going into the abdominal cavity. So deficit definitely will increase. So these are the earliest signs of perforation. A randomized controlled trial evaluated the use of vaginal misoprostol 200 micrograms before office hysteroscopy. This reduced the cervical dilatation and operative time and trauma. And when you embark a hysteroscopy on a postmenopausal lady, it has been validated to use 14 days of pre-treatment of vaginal estradiol so that you can get an adequate cervical dilatation. When you find a perforation, or suspect a perforation, abandon the procedure, check the hemodynamic status. Don't hesitate to proceed with a laparoscopy or a laparotomy. Always have people with you to counsel when you are doing a surgery, to counsel outside the theatre also. And hemorrhage, usually it happens in level 3 hysteroscopics. This is mostly controlled by unipolar coagulation or an oxytocin drip, or a Foley's catheter which can be dilated to around 30 ml. A skilled surgeon will almost always avoid this. And regarding the distension media, CO2 is obsolete now. Fluids with a very good hystromat with continuous irrigation allows clear picture and enables us to do a mechanical or electrosurgical cutting. Infection is very rare. In a retrospective study of 21,676 procedures, it has been found that is just 0.01%. Actually, prophylactic antibiotics are also not recommended while doing a hysteroscopy. A prospective observational study has showed that it is just 1.4%. Endometritis is around 0.9% and UTI is around 0.6%. Operative hysteroscopy intravascular syndrome. This is caused due to invasion of the distension media leading to hyponatremia, and if severe, it can lead to metabolic acidosis, pulmonary edema and cerebral edema. As I have mentioned before, remember the British Society Endoscopy Guidelines and European Society Endoscopic Guidelines. Do remember to go back and read the article which I have mentioned before for the fluid dynamics. And an air embolism, the basic tip I have told to avoid the basic air embolism which can occur at the outset of starting a hysteroscopy. And once you encounter it, avoid an exaggerated Tenelberg position. Height of irrigation system should be restricted to less than 1 meter and avoid nitrous oxide. And how do you detect this? A sudden decrease in the PE CO2 levels will occur, and dyspnea and chest pain. So how do you know that this has occurred to the patient? Of late, the anesthesia, which if at all you have to give anesthesia to a hysteroscopic patient, other than the office setting, the best is a epidural or spinal anesthesia also, rather than going for a short general or general anesthesia, because all these signs can be picked up very easily. Here goes the debate, is it transvaginal scan, SIS or a hysteroscopy? We can see here that hysteroscopy has a sensitivity and specificity. These are all the intrauterine pathologies which can be operated while doing a hysteroscope, and hysteroscopy is validated for all these procedures. And do we use hysteroscopy routinely for all our infertility patients is the topic of debate today. An insight study, trophy study have been done wherein hysteroscopy has been used for non-IVF patients and failed IVF patients also. None of these studies have shown that it is useful, but these studies had limitations because endometritis has not been taken into account, and 1/3 of the patients in insight studies did not have the pathology treated, and 45% of patients in trophy study which incorporated failed IVF cycle patients into the study had a hysteroscopy already done. So these studies actually are not validated. And let's see what our most famous Cochrane database system tells. It says that hysteroscopy has a moderate evidence to be used in recurrent IVF failures, but routine IVF, no. How is hysteroscopy evolving in modern practice? As reproductive endocrinology and infertility practitioners, I stands for infertility and IVF nowadays. And why not we optimize the womb where the fetus spends most of his time rather than spending more time on the culture systems wherein the baby is going to grow for 5 days. So much of funding is going into the culture systems, but there is less of funding to deal with the hysteroscopy and the studies. And regarding the cost, The setup will cost around $1,200. Procedure disposals will cost around $25, and it is a 20-minute procedure, as simple as a annual examination of a patient. A small take-home message: no question of endoscopy if Bozzini in 1805 had not used lantern and speculum, and there is no question of hysteroscopy if Pantolomei in 1869 hadn't used a cystoscope developed by Desemex to remove a polyp from a postmenopausal woman. As reproductive endocrinology and infertility specialist, it's time to rekindle office hysteroscopy for benefit of our patients. They deserve nothing less. Let us enjoy the little things in life. Thank you. I thank Fertygnan and Ferty9 Dr. Jyoti Madam and Suma for this opportunity, and Vox for this wonderful platform. Thank you.